in the treatment of HER2 positive breast cancer, we've made great headway in the last couple of years. We are curing many patients, and I think at this point, one of the hot topics is therapy de-escalation. So the first thing that we're going to talk about is the age-old controversial topic of anthracycline or no anthracycline in our HER2-positive breast cancer patients, and I hope that we've nailed the coffin at this point. Dr. Collins, can you talk about Train 2 for us?
Yes, definitely, and I think it's so exciting for our patients that we actually get to talk about de-escalation in HER2-positive breast cancer, which used to be a devastating diagnosis. And now we're talking about ways that we can treat them with fewer and fewer toxic drugs, especially in those patients that we would consider low or moderate risk. But what's exciting about the Train 2 trial is that these patients were relatively high risk early stage HER2-positive breast cancer patients. It was a phase 3 trial, and it evaluated an anthracycline-containing regimen versus an anthracycline-sparing regimen in combination with trastuzumab and pertuzumab in the neoadjuvant setting. These patients were all stage 2 or stage 3 HER2-positive patients, and the 3-year follow-up data is what was presented this year. And it ultimately confirmed that in most HER2-positive patients, anthracyclines are really just not necessary. Lead to, of course, more side effects. What we saw in this trial were higher rates of febrile neutropenia, which makes sense, symptomatic LV dysfunction, which again makes sense. It was still very rare, about 1% in this trial, but of that 1%, I believe it was a third of those patients never regained that LV function. So that's devastating in someone who is potentially curable. And 2 patients actually developed leukemia, which is, I think, a terrifying side effect that we are all concerned about when we give a patient an anthracycline. I think the caveat when we talk about removing anthracyclines from a HER2 regimen is that some patients with HER2 disease have disease heterogeneity, either within the tumor itself or even 2 subtypes of tumors. You may have a TNBC and a HER2 positive breast cancer simultaneously. And if we think back to ASCO, I think it was 2019, Dr. Metzger presented a study of neoadjuvant TDM1 plus pertuzumab in HER2 positive patients, and 55% of patients with your standard HER2 positive breast cancer achieved PCR, which we know of as a surrogate endpoint, but no patients with HER2 heterogeneity achieved PCR. So I think that we need to think of these HER2 heterogeneous patients as maybe a different subtype, and that's the area where I may still consider an anthracycline-containing regimen. But otherwise, I think I'm pretty happy to remove the anthracycline from my HER2 sort of toolbox.
I've actually never used an anthracycline in HER2 positive breast cancer because I'm in LA.
You're in California.
We don't do that. So
California leads the de-escalation of all therapies, I think.
My go-to regimen is Taxotere, carboplatin, trastuzumab, and pertuzumab. 6 cycles. That's what we use.
Yeah.
So I've used anthracycline twice for HER2 in the last year, but the reasons were, like Julie said, one patient, very HER2 heterogeneous disease, like the HER2 positivity was not impressive with a high nodal burden. So I felt she really needed a good traditional backbone, and it was estrogen positive as well. And the other, which I think maybe a bit more controversy, was a HER2 positive inflammatory breast cancer case. Again, quite significant nodal burden where I felt I just needed to kind of use everything. And I think there's some debate about how to best handle that, because it is obviously not an overly common situation either.
Absolutely. The time that I've used an anthracycline was a classic example of tumor heterogeneity. So we got biomarkers on both the breast tumor and the lymph node, and the breast tumor was HER2 amplified, but the lymph node was actually triple negative, and we repeated the receptors at least twice, and that's really what it looked like. So it looked like the disease in the lymph node was truly more of a triple negative phenotype. So that patient, we ended up giving an anthracycline to. But outside of that, I'm pretty TCHP is my standard go-to for either T2 or node positive HER2 positive breast cancer.
Do you typically do biomarkers on the lymph node as well as the primary?
No, it was it was somebody that came from the outside, and they had both been done, and so I couldn't ignore them.
Yeah. Well, taxotere plus carboplatin ought to kill the triple negative too, but that's still a little controversial.
PHP is certainly not always the easiest regimen either.
It's not.
We have a lot of these de-escalation trials. So we enrolled quite a few patients to Otto Metzger's trial that Julie mentioned with TDM1 and pertuzumab. So that was quite helpful to have. And then we had sort of a precursor almost to the HER2 Compass trial called the Daphne Trial, which looked at paclitaxel, trastuzumab, and pertuzumab. And if you achieved a PAT-CR with that, you just did the antibody therapy in the adjuvant setting. So we got to avoid a lot of TCHP use for a while.
I think it provides solace too that now in patients with residual disease, we have TDM1. So, you know, we also don't know, is there any role for an anthracycline? If you don't have a pathologic complete response, I can give you TDM1 on the back end, and I know I'm going to make up for that a little bit. And then this trial also just adds to the evidence of the BC-IRG-006 study that looked at TCH versus TCHP, and there was very, you know, no statistically significant benefit to the BC-IRG-006. It was
the adjuvant study.
Yeah, the adjuvant study. Yes, it was TCH versus ACTH.
Yep. Yeah, it was pre-pertuzumab.
Pre-pertuzumab.
With BCIRG, the only aspect that gives me pause was it was not dose dense AC for, you know, I think you could debate that. And then the curves do favor the anthracycline, but yeah, there was no, you know, statistically significant difference at all. But I think all these follow-up studies have been very helpful to help us stop using anthracyclines largely.
I think it's important to keep in mind that if you kill, you know, trastuzumab was the drug that really changed the prognosis of patients with HER2 positive breast cancer. And if you hurt their hearts before with an anthracycline, then you can't give them the trastuzumab. So that's not an insignificant number of people.
Right, I agree. So the next trial that we're going to talk about is the KATELIN trial, which was presented at ASCO in 2020. Julie, can you tell us about KATELIN?
Yeah, KATELIN was another phase 3 trial in early stage high-risk HER2 positive breast cancer. And it actually aimed to improve efficacy and reduce toxicity. But instead of taking away the anthracycline, they were trying to, they replaced the taxane and trastuzumab with TDM1, and this was in the adjuvant setting. Both arms in this study did receive an anthracycline and pertuzumab. Interestingly, there was a higher rate of discontinuation with TDM1, and there was no improvement in invasive disease-free survival. So this study, in my opinion, does not change standard of care, does not change my practice. But the pearl of good news that we can take out of this study is that even in a high-risk population, where many of these patients were HER2 positive, lymph node positive patients, the 3-year invasive disease-free survival was 93 to 94% among these patients. So I think that's what we learned from the KATELIN trial. And looking at the TRAIN2 trial, in addition to the KATELIN trial, I think these trials support the fact that we all, I think, would agree that neoadjuvant adaptive trials looking at escalation and de-escalation based on whether a PCR is achieved or another surrogate endpoint is achieved is a space where trials are actively accruing and where we really need this data. And then chemo-free regimens are also attractive, especially for lower risk HER2 positive patients, and those are also being evaluated right now. So I think there's going to be, even though outcomes are really good with our HER2 positive patients, I do think that we will see some movement in terms of how we're treating these patients in the years to come.
I think it was incredibly unusual that more people on the TDM1 arm discontinued treatment, because that's not usually something that I think of as being particularly toxic compared to a taxane. just very strange.
Study, the taxane was stopped, right, and trastuzumab completed the year. So I am finding we've had studies looking at TDM1 versus trastuzumab. I don't know if anyone had the ATTEMPT study open that was presented at San Antonio, but even though the early efficacy looked similar, I think it was surprising that tolerability wasn't better with TDM1. But I think when you compare 12 weeks of a taxane versus a full year of TDM1, I think you can see why, maybe overall then the tolerability ends up being not so different, because, you get those 12 weeks done and then you're on to trastuzumab.
In your experience with your patients, why do they usually go off of TDM1?
I've had more trouble with elderly patients on it. I'm finding they're more fatigue, more neuropathy, and I wonder if some of it is some baseline comorbidities as well. Yeah. But I have been surprised that, some people it's like a walk in the park, and others do seem to have a really tough time. So there'll be additional trials looking at perhaps shorter versions, shorter number of cycles of the TDM1 than switching to trastuzumab, because I think it's hard to get, much easier than trastuzumab monotherapy.
Right. TDM1's a great drug and generally well tolerated, but I agree. I had an older patient just yesterday have to come off TDM1 for neuropathy, but she was already starting with neuropathy given her prior history of taxane. So I agree. I think where we stand right now, it sounds like most of us are treating T2 node positive tumors with neoadjuvant TCHP, sparing the anthracycline for maybe tumor heterogeneity or maybe an extremely high risk patient like inflammatory breast cancer. And then since the Catherine data, we're really looking at their pathologic complete response, which is an extremely important endpoint. Laura, I know you've done a lot of work, pathologic complete response rates. So, then we move on to TDM1 if they don't have a complete pathologic response and they're able to tolerate it. And then if they do have a pathologic complete response, which is a large portion of our patients, I think most of us are doing either a year of trastuzumab or trastuzumab plus pertuzumab. What patients are you continuing a full year of pertuzumab on, and what patients are you, after a pathologic complete response, saying enough's enough, trastuzumab for the year is what you get?
Definitely patients with a high nodal burden up front. I'll continue the pertuzumab if they can tolerate it. That being said, if they're having significant side effects or toxicity, and we do even see sometimes neuropathy from the pertuzumab, so something that I would be concerned about potentially long-term, I'll pull back. But I'll try to start it in patients who were lymph node positive.
Who were originally lymph node positive.
Originally.
Cleared their lymph nodes. Yeah, I agree. That's who I'm using it on at this point. And I think the update from Affinity showed us that ER positive, ER negative didn't really matter. They still got a benefit of pertuzumab if they were in that node positive population. So these patients get neoadjuvant TCHP. We take them to surgery. Oftentimes lately, I'm seeing their HER2 get retested on the surgical specimen. Despite me not really wanting it, we see it. And then we don't know what to do with it, but oftentimes that, because of tumor heterogeneity and because with the TCHP, you're really, weeding out that HER2 positive clone, the residual disease is no longer HER2 positive. So there was a presentation this year at ESMO based on a subset of the Catherine data that really looked at this and what are the implications of losing HER2 in the residual breast cancer. Laura, can you tell us about that?
I can.
Oh, Callie, I'm just kidding. Laura's like, no, I cannot. I cannot. Callie, tell us about that.
It's not common in my experience that you have residual disease left over that's HER2 negative, but we definitely test again after they've if they still have disease remaining from their neoadjuvant therapy. And for my patients, it's been more common to have a hormone receptor positive HER2 negative disease left over because it's slow growing, doesn't respond to chemotherapy very well anyway. So the Catherine trial was a phase 3 clinical trial in which patients with HER2 positive breast cancer were treated with neoadjuvant therapy. If you didn't achieve a complete pathologic response, then patients were randomized to trastuzumab versus TDM1. So in this patient population, there were some who didn't have, were retested basically and did not have positive HER2 tests. It was a low number of patients, about 70, which was 8.3% of the population. But because the enrollment criteria was HER2 positive disease before they got their neoadjuvant therapy, these patients went on to be randomized into Herceptin versus TDM1 anyway. So in this subgroup analysis from Catherine, it looked like that the patients who were randomized to TDM1 did better than the patients randomized to trastuzumab, even though they didn't have HER2 positive disease after neoadjuvant chemotherapy. So the data point that Sybil Loibel presented at ESMO Breast was that there was no invasive disease-free survival events among the 28 patients who had been randomized to TDM1, but 11 events among the 42 randomized to trastuzumab. So very low numbers, but maybe patients with HER2 negative disease do have a benefit in TDM1. Have you guys had experience, and what do you do?
So this has been something we've debated at Tumor Board.
Yeah.
So I was actually really happy to see this presentation at ESMO Breast, because at least it helped put that debate. I agree, small numbers, but at least it was some data, because that's what we all want to know, what do those specimens look like after? I agree, clinically, we don't always want it, but
Yeah.
We know probably some patients were tested. So I think one thought on it is, does the residual disease specimen truly represent micrometastatic disease elsewhere?
Exactly.
And perhaps could that be why this was seen? But again, the numbers are small. And the other big area we debate is, how small do you go with switching to TDM1 for residual disease? And again, the Catherine trial suggested that even if there's a very small amount of residual disease, that it still makes sense to switch. So I've been switching patients, but I do always say, we can have a low threshold to switch back for someone who, has really minimal residual disease left or has residual disease that's HER2 negative, because it's just, hard to imagine the benefit is quite the same.
Also, given the new trastuzumab deruxtecan data, and we know that there may be some activity in HER2 low, it also makes me wonder, does TDM1 maybe have some activity in these residual micrometastatic tumor cells that may be HER2 low? I don't think we have any data to support that, but this very small data set does make us feel more comfortable randomizing those patients or giving those patients TDM1 if they lost the HER2 on the residual sample.
Are any of you routinely testing the residual disease?
We do, yeah, at UCLA.
Seems like my pathologists do. I think we are pretty much very routinely testing. And also, the other question has come about, in these patients that lose HER2, do you then need to give them an anthracycline if they had residual disease and then they lost HER2? And in a case that we recently had where the patient did lose HER2 and they had a decent residual nodal burden, we then ended up giving them AC and then TDM1, which seems like overkill, but it was a lot of residual disease that had lost HER2. So that's a point of discussion as well, I think.
And it was a hormone receptor negative residual disease.
It was actually hormone receptor positive, but they had, a pretty large nodal burden. And, in high nodal burden, hormone receptor positive disease, there is a benefit to an anthracycline, at least from the ABC trials that we know of. So.
And then you could do neratinib after Kadcyla. I mean, that hasn't officially been studied, but it's an option out there. And it could prevent brain mets. So
it's true in really, really high risk people. It's so hard to get people to commit to something after a year of adjuvant therapy.
It is. Even a pill.
Especially something that carries such a high rate of potential, GI complaints. That's the last thing they want after so long of being on therapy. And
especially if they struggled with Perjeta.